increase the threshold for pain. So, this is probably why in some people it was well tested in, for instance, knockout mice. In some people, under some circumstances, a cold is felt as pain. This is, and what is probably will be most difficult for us. It's a huge chance that the brain reads not the sum of those cold and warm information, but the pattern. So, and simply it learns some pattern and is simply accustomed to pattern. When the pattern is changed, there's a new response. Sometimes positive, sometimes negative. Thank you for your attention.
Thank you very much, Professor Wierzba. That was really astounding how this simple process can be so complex. I think that was a lot of interesting information. And if anyone has any questions, we will probably do the occasion to ask them after the second little bit shorter presentation. And here we have more of a clinical eye on the whole subject from Dr. Kamil Kowalczyk.
Thank you very much for invitation neurologist to this discussion. My name is Kamil Kowalczyk. I work in the Department of Adult Neurology, stroke unit, and I hope I will present the importance of the receptors for temperature and touch in neurological clinical practice. As we know, the TRPV1 is activated by painful heat, as Professor Wierzba nicely presented, is involved in a variety of physiological processes. However, after exposure to capsaicin, sensory axons that contain the TRPV1 receptors are desensitized, which inhibits the information of pain transmission. These receptors are also involved in neuropathic pain and in the treatment of the neuropathic pain. Generally speaking, topical exposure to capsaicin leads to sensations such as pain, burning, or itching. However, high concentrations of capsaicin or repeated application can produce a persistent local effect, which is called defunctionalization, and it causes reduced spontaneous activity and loss of responsiveness to a wide range of sensory stimuli. The process is complicated, and I'm not going to discuss it. What is a neuropathic pain? By definition, neuropathic pain is any pain caused by a lesion or disease of the somatosensory system, and it is a consequence of a pathological maladaptive response of the nervous system to damage. And what is important, neuropathic pain is present in the absence of any noxious stimuli. So we do not need this type of pain. And what are the most common causes of what are the most causes of neuropathic pain. These are very quite often diseases such as diabetes, in which we may have painful neuropathy, shingles, limb amputation, neuropathic pain after surgery or trauma, when there's also trauma to the nerves, stroke or spinal cord injury, trigeminal neuralgia, HIV infections, and in some patients the cause of neuropathic pain may be unknown. So let us start with post-hepatic neuralgia. As we know, herpes zoster or shingles is caused by varicella zoster virus, and shingles typically presents with rash that at the beginning is painful, but usually it is self-limited. But some patients may have continuous pain after the rash resolves. And as we know, shingles or herpes zoster results from reactivation of latent varicella zoster virus that is present in sensory ganglia, and it was gained during varicella or chickenpox. So in post-hepatic neuralgia, we have localized neuropathic pain which lasts more than 90 days, so more than 3 months, but the pain is localized in the same distribution as the preceding episode of acute herpes zoster. Pain is in its nature burning or pruritic, sharp, stabbing, and maybe either constant or intermittent. Typically, herpes localizes to 1 or 2 dermatomes. The dermatomes which are most commonly affected are trigeminal nerves, cervical dermatomes, and thoracic dermatomes, so T4 to T6. And the pain in patients with post-hepatic neuralgia may be on one hand severe, and on the other hand may be associated with profound psychosocial dysfunctioning, including but not limited to impaired sleep, decreased appetite, or diminished libido. How frequent is post-hepatic neuralgia? It is estimated that it is present in about 10 to 15% of patients with herpes zoster, but the rate of incidence is higher in older patients, so it's present in about 20% of patients older than 80 years. And how we treat post-hepatic neuralgia? Generally, treatment is difficult, and patients very often need a multimodal therapy. What can we give patients are gabapentoids, so anti-epileptic drugs such as gabapentin or pregabalin. We may give antidepressants, cyclic antidepressants such as amitriptyline, nortriptyline, or desipramine. In some patients, we can also use topical therapy, especially in patients with mild, moderate, and localized pain. So, for example, we can give capsaicin or or lidocaine, and there are numerous alternative therapies. The first study on capsaicin in post-hepatic neuralgia was published in 2008. It was there were more than 400 patients in which or who had application which lasted 1 hour. It was application of 8% capsaicin, and there was also parallel group, so placebo group, in whom the researchers administered low concentration capsaicin patch, and they checked the pain, and the authors concluded that capsaicin provided rapid and sustained pain relief in patients with post-hepatic neuralgia. So the pain relief started during the first day after the application, and it was seen in up to 12 weeks. This study was repeated by another researchers, and systematic review from 2017 concluded